Next, we have Michael with us, and he is a very renowned glaucoma surgeon in Melbourne. He's talking about the risk management strategies in glaucoma surgery.
We are going to change gears a little bit, and I apologise because I've been in health governance for 19 years, and so I'm going to take you on a very brief tour of risk management, at least as organisations see them, and see if we can convert a little bit of that into our own behaviour and how we think about things. Obviously, the first problem is loss of vision. We're dealing with a disease that causes people to go blind, so we have to think about why does it still do that. We have all these tools that are available to us. I think the first thing you have to do is think a bit like an engineer. Engineers are really good at risk management. They really talk about it, they think about it, they sort of live and breathe it. And of course there are risks in doing things, bridges that don't hold up, but there's also risks in not building bridges. People sink swimming across rivers. So it's very important when you're considering about what you're doing to a patient that there is an actual underlying disease here that'll take their vision if you don't do something. Now, in a perfect world, risk is actually identified. A risk is discussed. It could be a kind of macro or a micro risk. We're talking about a sort of macro risk of a disease, but there could be a micro risk of exactly how you put in sutures or what happens 10 years after using Prolene sutures. But they should be identified, should be described. In fact, if we can, the likelihood of the risk being calculated. How often does that risk come in? And then we have things called controls around risks. The formal statement is if you use nylon instead of Prolene, that's a form of control, using something different. And the controls are put in place to manage the risk, and then there's the effectiveness of those controls. Now, in a lot of industries, they do this really well. If you look at Coca-Cola's sort of annual report, they're going to be able to do this really well. They'll be able to tell you everything from reputational risk to a whole lot of other things almost perfectly. And in medicine, we almost never use this language at all. And this is how I think we have to consider these issues. Now, one way to do it is to think about a clinical risk review. I know whether you've been involved in these things, they're often pretty tiresome and difficult, and I don't apologise for them. They do have to be somewhat exhaustive. Now, the opposite side to this, of course, is medical quality. This is a language that you'll often hear, but its underpinnings are risk. What you're really trying to do, one way to think about it is that medicine is expensive and difficult because we manage such significant risks. And we have such an amazing amount of education trying to do that, but instead of managing the risk, what we do is we substitute expertise. We increase the amount of education we have. We don't manage the risk itself, we increase the capacity of the people to manage the risk. That might sound a bit obtuse, but it's a kind of way of thinking about the problem. There is two different things. One is error and the other is harm. So error is where you just cock up. The other is where you cause harm by doing something, but what you might have done is the right thing. We're talking about these people obviously need tubes, they need trabs, they need some sort of intervention, but it causes harm. And if you acknowledge it's causing harm, then you have a way of getting around it. You have a way of identifying that and doing something about it. So there are errors in glaucoma management. One of them is diagnostic, we didn't get it right. The other is we do the wrong management. Not too hard. There are problems with diagnosis and also staging, so getting the wrong level of disease. I think most glaucoma doctors have the experience of they've made the diagnosis, we've got no idea of how bad it is, and you're staring at this nerve thinking, boy, if the wind changes, they're going blind. So some of that is a problem with not looking, not knowing, and data error. And then there's harm in the treatment, of course. What we do, we cause harm, and we might cause more harm if we treat something where there's no disease. We might also over-treat the disease if we're not careful, and we've talked about sort of graded ways of attending to it. Now, all that's just a framework, it's just kind of the background stuff. There's a guy called James Reason who wrote a book around how does risk management organisations. It's a fantastic book, you can still buy it. It's in Courier typeface, it must be the only book that's still available that's written in Courier typeface. And it's a wonderful read, it's actually really readable. But he talks about the Swiss cheese model, holes in it, lots of cheeses have holes in it, not just Swiss cheese, but anyway. There's another article, if you're interested, a guy called Richard Bomber, who was actually a New Zealand physician who became a Mayo consultant and then in fact a health consultant. And he talks about the 4 habits of highly effective health organisations. And there really are essentially specification and planning. How do you segment your offering to patients? How do you make the infrastructure appropriate for the issues? How do you get measurement and oversight embedded into the organisation, and how do you add self-study? It's a sort of takeoff of the 7 habits from Stephen Covey. De-risking something is using risk management, but risk management itself is somewhat risky if you don't really know how to apply it. So I'm sorry about this somewhat tautologic phrase, but what you're really trying to do is work out what risk are you managing. Some of them are bricks and mortar, some of them are the proline versus the nylon, and some of them are the macro. How do we educate enough people so that we can actually treat this disease adequately in Africa? They're all risks, and we can put them in, and some of them have much more complicated solutions than changing suture material. And you have to know where that risk is in this profile. So the first one is misdiagnosis. How do we deal with that? So we know that still a significant portion of disease is undiagnosed. Some people even say half of it. Not sure that's true anymore, but potentially it is. Certainly a lot. Disc examination ends up being a key skill. There's a whole lot of other bits to it, but that's probably the one that we have to use. So disc examination is not only a diagnosis, but it's also a severity question. We developed, George is in the room as well, this thing called the GONE program, and really what we did was we interrogated how people were making errors. And that went on the net, courtesy of George. The poor fellow is still trying to keep this thing limping along with no funds. Promise we'll get some soon, George. But they're called free online medical education. Right? That's called a FOAM. And this is one way to democratise education across the world, and it's a way to actually de-risk it. If you're talking about the risk of going blind as a worldwide problem, you're going to have to tackle the education component in a worldwide sense. So that's FOAM. They're really gathering some pace, and there'll be some AI and various things you can do to that to make it better. They're some of the publications. Just some real snapshots of this, things that are obviously really easy to detect on the left-hand side. As you look at it, disc hemorrhage, notch, everyone sort of got it. The one in the middle, everyone said that was normal, but the one on the right-hand side, these are glaucoma specialists. There was a huge range. Okay, now that person on the right-hand side definitely has glaucoma, but for whatever reason it was difficult, so we interrogated why it was difficult. Consistency was also something that was really interesting. 3 of the same person spread over 3 months with disappearing disc hemorrhage, and what you found is expert observers were much less affected by the disc hemorrhage, and unexperienced trainees and optometrists were highly affected by it. So when 1 and 2 were compared, or 1 and 3 I should say, where there's no hemorrhage and there's an obvious hemorrhage, optometrists collapsed in their capacity to differentiate. So there's a very interesting component to how people are assessing this. What goes wrong, I think you broadly know these sorts of things. Big discs tend to get sort of overcalled. Smaller or medium ones sometimes get undercalled. Disc tilt, often that's a little bit of a problem, but there's certainly a lot of overcalling and vertical. But CDR, if you miss the CDR, I know there's lots of reasons why CDR is not perfect, but it's actually hugely important to see if you get a crack at it. And peripapillary atrophy and cup depth and all these sorts of things you could pull apart. If you would like to look at it, you can. There's been over 33,000 people now enter it, so it probably is the largest online medical education, certainly in ophthalmology, and it's reached over 50 countries in the world, including pretty high take-up here in India. Obviously the highest is in our area. And you can get further training in this. We did the training stuff. So now the macro risks. The macro risks of glaucoma treatment. One of them is under-treatment. There's treatment itself, and then there's over-treatment. In fact, when I talk to patients, particularly second opinions, as you get older and grey, you see more of them. You know, and people come and say, well, do I have glaucoma, doctor? You know, well, you might. Sure. I don't know. It's a progressive disease. If it doesn't progress, you probably don't. But you certainly have a risk, and this is how we're going to manage that risk. We're going to have a conversation about risk. So under treatment, obviously you can miss the rate of progression, you can do all sorts of things that reduce patient compliance, you know, all those sorts of things. A rate of progression, just for a moment, is worthy of thinking about it because it's very different if you consider it from a CDR point of view, if you consider it from an axonal measurement point of view, if you consider it from a visual field point of view. Everything has sort of got a curve in it. So when you're sort of thinking about where someone is in this, just be careful that it's, you know, you've got in your mind. Outflow is another thing that's very non-linear. You know, if you get to essentially 50% reduction in outflow, your pressure will go, if you calculate it, from 15 to 21. If you halve it again, it goes to 40. We are very non-linear stuff. Almost everything in glaucoma is not linear. If someone shows you a graph of something linear, they just haven't done it right. I promise you, it's not. It is almost never true. Probably in all of Anyway, we also now rely much more on data, of course, and all the things that we rely on, intraocular pressure's got all sorts of problems, ACTs, you know, sometimes random number generators. We see lovely pictures of them, but I'm sure in your clinic you have ones that you just throw in the bin. Visual fields, people have bad days and dry eyes and this sort of stuff. So what you're really trying to do is interpret flawed data. Calibration of intraocular pressure based on CCT, you know, it's almost meaningless in clinical practice. It's a really interesting thing to do. It might mean something if you've got very thin CCT, but otherwise it's probably not particularly relevant. Treatment. Lots of treatment has risks, so that has to be planned. All of these sorts of things, if you consider it as risk, these are the sorts of things that you can intervene about. These are the sorts of risks that are attached to it. We've heard a little bit about those things, but I want to remind you, I should say, that risk is a combination of likelihood and severity, so you just need to consider that with each of the things you're talking about with patients, and remember that harm is something that is hard to get rid of. One of the problems that we have with glaucoma, particularly surgery, is we really don't have a sense of how much flow we actually need. So one of the things I will constantly remind you, in a perfect world, what you want is 2 microlitres a minute at 10 millimetres of mercury. That should be your light on the hill. Everything else is kind of a sort of, one of the problems, and we had this conversation, Shannon and I, about the problem of what happens in the subconjunctival space, and could you actually model that properly? Target intraocular pressure, as you know, is a somewhat theoretic concept. It's kind of nice, but it's often in retrospect. Again, I wouldn't hang my hat on that. There's a risk attached to that. So these are all kind of risks. These are ideas that we have that carry with them risk. I'll kind of run through this. There's topical medication that causes problems. There's risk of laser. There's ability to detect change. Can we even tell that? How long? There's a risk of no surgical intervention. So operations do work. All of us in this room do operations, but they have to work. So there has to be this second part of it when you're talking to a patient saying, there is a risk if you do one operation, the patient won't have another one because it's failed. It has to be a statement that says, this is what we want. If we do not achieve it this way, we'll then go on to the next one. That's a micro risk about how do you manage patients' expectations. There's a few things around this, but one of the things I talk about is lowering your standards as a physician. As you go along, if someone needs one medication and they're at target pressure, that might be okay, but if they're outside their kind of assembled target pressure and they're on 2 medicines, they've failed. You need to kind of man up and get on and fix the problem. You can't just sit on it. So the risk is of surgeon, not indifference, but tolerance. We won't go through that one. So why do we make bad decisions? There's all these risks that we know about and how businesses make decisions. There's confirmation biases and all those sorts of things. This is all the language that will govern how you behave in this space. Overtreatment. We know that the problem with glaucoma is that there is no difference between good treatment and no disease. You treat it to no change. So if you really do treat things really well, there'll be no change in the disease, and if they didn't have glaucoma in the first place, there'll be no change. Just as a thought experiment, if you looked at that disc differently based on the pressure, you're wrong, because the disc is an independent piece of information. You shouldn't think of it differently. Changing conditions, people get older. You assess their risk based on their prior. They get older, things change. Risks need review. Patient literacy, engagement, all of these things you know. I tend to suggest to people that we tell a story every time. We tell them where they are in the story, where their risks are, what is altering. At least once a year I'll go through essentially why the patient is coming, what they're doing. I think it's enormously helpful for them as well. I describe it as a road going forwards with a certain amount of illumination from the headlights. And sometimes that means you'll need to be seen more frequently, sometimes less. And then finally, there are systems in place and you have to trust others. In our system, that's often optometry, but you need to be a bit careful about the data that you're getting. There are wonderful cartoons in the New Yorker on occasion, but I think that one's quite a lovely one. It is quite possible that people are telling you things that aren't correct. As a final idea, the value of another set of eyes on a problem. So the Mayo doctrine, and I hope I'm quoting it correctly, is that you should practice as though you're in a glass box so that everyone can actually observe what's happening and they would agree with what you did. And I think of the counterfactual. What is it if this is not glaucoma? What else could it be? Richard Feynman was a wonderful person in terms of risk, and he was the person who discovered that the silicon was wrong for the O-ring and the Challenger disaster. And after NASA had said there's a 40,000 parts and there's a 1 in 40,000 failure rate, therefore all of the space shuttles are going to crash. And he said, that's crap. You used the wrong silicon. Don't make risks, don't make them more complicated than they need to be. Thank you.
Thank you, sir, for your insights and the illustrative presentation and helping us look at the engineer perspective as well.